एक मिनिट.
Yeah.
Okay. Live.
Continue, madam.
Hello.
You're live, madam.
Okay. Good morning, everyone. Very warm welcome to the first webinar that is organized by IAP and IAP Women's Cell Gujarat. And this has been a new tenure for IAP, like the new IAP which has taken place from 2020 onwards. So this is just the first step that we have taken, and in future there are going to be many more things that we are going to bring for students, for the academicians, and for the clinical therapists as well. Okay, and it's a very proud moment for us that we are jointly organizing this seminar with IAP and IAP Women's Cell Gujarat. Okay, so on behalf of entire IAP and IAP WC, myself, Dr. Dhara Sharma, President IAP Gujarat, I welcome you all to this webinar. There are few things that I wanted to mention over here is that the kind of response that we have got from the participants, that is so overwhelming that, I am hugely thankful to all of you for showing such keen interest in for the subject and showing such affection for the subject and your eagerness to learn. So I'm really thankful. Without you all participating in this, we wouldn't have been able to make this seminar or this webinar this huge success. So I'm really thankful. Other thing that I would like to mention here is that I'm really grateful to Parul University and Gaurav sir for giving us this platform so that we could reach to all of you. Okay, we had so many inquiries pouring in, and then I was feeling little bad, even ma'am was feeling little bad that we had to say no to people who were so eager to learn. So at the very right time, Gaurav sir and Parul University came to rescue, and we are very grateful that you have provided us this platform, sir. Thank you. Let's talk about the webinar now, so that we are going to learn EMG and NCV, and usually it is a topic, electrodiagnosis, that at student level and even those clinical therapists who are practicing it, they may find it little tricky, but then the webinar title itself says it made easy. So you can imagine that, with the like the caliber of the teacher, that how she is going to make it so easy for us. Okay, Nehal ma'am, none other than her would be most appropriate to taking this topic for her topic for us. Let me tell you something, some brief introduction of Nehal ma'am here. So there was one quote which I could very appropriately find for her is, develop a passion for learning, and if you do, you will never cease to grow. How exemplary life that she has lived, and because of which, that quote fits most appropriately to her. Ma'am is working as a principal in SBB College of Physiotherapy, Ahmedabad, and she has been certified practitioner and trainer from American Academy of Electrodiagnosis USA, and she was the very first one to achieve this in the year 2014 from India, Gujarat. And the certification what she has got, that is accredited by APTA, and since then she had been relentlessly making sure that we all, the physio fraternity, learn EMG NCV and we get into the practice of it. So I'm very thankful to you, ma'am. So without wasting much of the time, I would like to ask Gaurav sir to go ahead with it, and then eventually Nehal ma'am will take over. Thank you very much.
Thank you, Dhara madam. As madam has already told about
Gaurav sir, can I interrupt you?
Yes.
I'm getting a lot of messages from a lot of people.
I'll manage it. I'll manage it.
Yeah.
Yeah. Thank you, Nehal madam, for providing such platform to arrange a webinar for the EMG NCV study made easy. Uh, so I'll hand over the session to the madam to continue to the webinar for the EMG NCV study. Thank you, madam.
Well, thank you very much. I would like to first thank Bhavna Gadvi madam, who first approached me, and she is right now the head of Women's Cell Gujarat. And then we just had a thought, three of us, me, Dhara madam, and Bhavna madam, that why not have it on IAP platform so that more and more people come to know about it, more and more people listen to it, and most importantly, we are here for upliftment of our profession. So thank you very much, Dhara ma'am and Bhavna ma'am, and yes, Gaurav sir, because you came to rescue at the last moment. We were just struggling, and I don't know how many webinars would I be holding if this would have been there, because I have got inquiries from all across the country, and I guess Dhara ma'am has got this from across, even outside India. So right
Yes.
now we are having viewers and listeners from across the globe. So that makes my task more challenging, because when you see this across the globe, you have to meet to the expectations. I have tried my level best. I hope I meet everyone's expectations. And thank you, everyone. And yeah, I'm ready to start. Gaurav sir, are there? Can you just see regarding the streaming whether people are there, not there? So I think I should start now. Dhara ma'am.
Actually, ma'am, there are a lot of messages that are been going on, which says that they are waiting and not able to join. So at least we must do something for them. Maybe
Yeah,
we
so
can
I'm
wait
not
for a couple
starting
of
right now.
minutes.
Yeah.
Yes, and then we can start. Yes.
Yeah, because even I am getting messages from a lot of people.
Yeah, madam. I'll just try getting that particular message, and just you can continue session. I'll take manage that.
No, but then people will miss that, right?
We can
Yes.
also video also that उसका YouTube video share कर देंगे. You can continue.
Because most of them are getting the message that the stream is not available to your organization.
I'm just दूसरे device में already it is running.
Okay.
Somehow एक साथ मैंने wrong password डालते हैं, उसकी वजह से might be कैप्चा आ जाता है, इसकी वजह से कुछ error आने की possibility है.
Sir, कुछ तो हो रहा है, because one message that I have got is they have to change their accounts. So I don't
Yes.
know what is that.
Actually, ma'am, the login process is such that people don't have to just join in from their Google accounts, but from the Google account of Parul University. So they have provided the ID as well as the password for it. So they have to join through that.
Yeah, but people have tried doing it. We
Yeah,
can
but
tell
still,
people
many of
don't
them,
join from your.
many are facing.
Maybe because of that, they have to, I think, log out from their account and then start with the Parul account, right? Parul University.
People
Yes.
can add people can have a option of add account. People
Yeah.
can have option of
Yeah.
add account. They can go into add account, just add account with a user ID, user ID and password, and they can continue.
Yeah, sir, that I had already conveyed to the group.
One of my students has written it's difficult. They have to join through Parul University account and then to have to refresh a lot. It is difficult.
क्योंकि હું લગભગ લેપટોપમાંથી જોઈન કરું છું તો લગભગ મારાથી થઈ રહ્યું છે સેમ લિંક પર.
પણ સર તમે એટલે નોન પારુલ લિંક પરથી કરી
નોન
રહ્યા છો?
પારુલ પરથી પારુલનું જો આઈડી પાસવર્ડ છે ને વેબિનાર વાળું એ તમને જો સ્ક્રીનશોટ એના મોકલી આપો.
All right, I think we can start.
એનું યુટ્યુબ પર આપણે શેર કરી દઈશું મેડમ. એવું જે લોકોને ડિફિકલ્ટી લાગતી હોય ને પછી એના પરથી ઈમેલ એડ્રેસ મોકલી આવી દઈશું કે જે લોકોને ડિફિકલ્ટી લાગતી હોય કે ક્વેશ્ચન્સ હોય એ વસ્તુ એ લોકો પ્રોવાઈડ કરી પૂછી શકે.
Do we have the numbers that how many of them are already there? So at least we know
બ્રિજેશભાઈ અત્યારે છે નહીં પણ હું તમને કરી આપું.
Acha.
No worries, we
Okay.
can start because I'm getting
Yes.
messages from quite a few people that they are able to log in.
Okay, fine. Yes. I also got quite a few.
All right, so then without wasting much of time, I think we should
Yes.
start.
Yes, ma'am.
All right. And so once again, good morning, everyone. Well, I know that many of the people feel that EMG NCV studies are quite difficult, and it is not a cup of tea of a physiotherapist to do it. But I've been doing it since last 23 years now, and I haven't faced any difficulty except for a few resistances in the past. But now I'm okay, well to do, and I guess across the globe. And one of the very senior physiotherapists, Madam Dastoor, had said that physiotherapists are the best people to do EMG NCV studies, and I take that quote ahead, and even I agree to her that EMG NCV studies are best done by physiotherapists. So I always follow this quote: if you don't build your dream, someone else will hire you to help build theirs. And so this is for the new generation, the budding generation who are coming up, that please have a dream and make all efforts to fulfill them. Electrodiagnosis is a method of obtaining information about diseases by passively recording electrical activity of body parts or by measuring their response to external stimuli. See, what happens here is there is a lot of electrical energy generated within the tissues of our body, which are of very low amplitude, of course. And so we are trying to record those activities, and we are trying to see whether it is normal or not. So electrodiagnostic testing of nerves and muscles measure the electrical activity of nerves and muscles. We are able to determine the cause and extent of nerve damage by doing NCV studies, and whether any muscle problem is present or not, or neuromuscular problem is present or not, we can come to know by doing the EMG study. Just give me a second. We have nowadays a lot of sophisticated gadgets which are used for diagnostics, and the most in trend right now is the MRI. And so my question is, when we have tests like X-rays, CT scans, and MRI, why should we go for EMG studies, which are very, very painful and which are a lot of time consuming? Believe me, one EMG NCV study takes around 1.5 to 2 hours, and it is painful. Yes, there is a lot of pain, because when we sit to do EMGs, at times we are exploring 8 muscles, 10 muscles in a patient, and which is of course painful. Still, the information provided by EMG NCV is functional. See, when we look at an MRI picture, we come to know that, say, for example, when we are talking about a spinal ailment, we come to know that a disc is compressing the nerve roots, right? But then these findings are, supposedly found in a lot many of people who are even asymptomatic. So if we just look at MRI and try to conclude that there is a compression of a spinal nerve because of a disc, I'm sure it's not going to suffice, because then we will be probably over-treating a patient, or the patient would go under a knife and for no reason, right? So in that case, when we do EMG NCV, we are trying to check the functional integrity of a spinal nerve and the functional integrity of the muscles supplied by that spinal segment. And that tells the practitioners how it is, and that would probably give us a better idea, right? So MRI study is a test that simply provides the picture of anatomy. Electrodiagnostic testing can be an important adjunct in the diagnosis. So the benefits of electrophysiologic testing are, it correlates physical examination and other studies. This is most important thing. Whenever you are trying to do this kind of electrophysiological testing, we have to do a thorough clinical examination of a patient. We just can't keep beating around the bush doing nothing. It gives us a definitive diagnosis in the nerves and muscle disorders. It localizes the lesion, and it determines the physiological status of a lesion. Physiological status means whether the condition is acute, subacute, or chronic, whether the nerve is degenerating, whether the nerve is regenerating. If it is regenerating, how much is the regeneration? And it helps us in getting the prognosis. And of course, it gives us a good data for the clinical side and for the lab research. And believe me, understanding electrophysiologic changes will change the way you practice and improve clinical skills. There are a lot many many conditions where if you know this kind of electrodiagnostic findings, you are changing your patient outcome. The best example to this I can give is, say your patient is coming with lateral epicondylitis. All of us, we call it as tennis elbow. And we have tried all our measures, all our physical therapy modalities, the manual therapy, taping, everything we have tried, yet that some pain is there which is not going. And then we are always worried that the patient is taking the treatment, till that time patient is fine, patient comes back again with the same pain, or patient does not improve. What can it be? Now, if you know entrapment syndromes, there is a condition which is known as supinator tunnel syndrome, which compresses the radial nerve between the two heads of supinator, and the clinical findings mimic lateral epicondylitis. So had you been knowing electrodiagnostic testing, had you been doing this kind of testing, you would come to know that this wasn't the lateral epicondylitis, the condition was something else. So we have wasted a lot of time, lot of energy with no gain. So this could have been one of the, if a patient is not responding to our treatment in just few settings, we could have done this test and we could conclude that patient has this. A patient has some radial nerve entrapment across the elbow, around the elbow, and that is giving this problem to the patient. So this we can have a total new outlook to our patient care. The tests which we usually performed are nerve conduction studies, electromyography, lead responses, decrement responses, evoked potentials, and intraoperative neuromonitoring. Grossly, the equipment that we are using is a bit different from a routine physical agent that we are using, or even our routine electrical stimulation. So grossly saying, this is the equipment, and the entire instrumentation is divided into the input phase, the processor phase, and the output phase. The input phase is the patient, the part which we need to examine, or the nerve or muscle which we need to examine. And we will definitely put our electrodes over that nerve or the muscle. and that forms the input phase, because the activity produced within the patient's body would be recorded by this electrodes. So we have got an input now. Whatever activity we are recording is a very raw activity which has to undergo a series of rectifications and a series of refining, and which is done by the preamplifier, which becomes the part of the processor phase. Along with the good activity, the electrodes also record a lot of other activities which are there in our surroundings, in our environment, like the artifacts that are coming from our mobile phones, that are coming from our ACs and fans and everything. And everything comes under the recording electrodes, goes to the preamplifier. The preamplifier refines it. It removes all the unnecessary things, and what it gives us is the activity that we need, activity that is coming specifically from the nerves and muscles that we want to see. That activity is then amplified by 1000 times, and this becomes the processor phase. And from that, we can see something on the screen. It is a computer. So that becomes our output phase, where we can see a signal, we can listen to a signal, and since it is a computer, we can record that signal. So this is the gross instrumentation, wherein the patient and the electrodes put on the patient becomes the input phase. The preamplifier, where the signals are refined, filtered, and then magnified, becomes the processor phase. And then what we see on our computer screen and we listen, we store the data, becomes the output phase. And this is how the machine looks like, wherein this box is consisting of our amplifier. We have this sockets wherein the electrodes come out and they are put on the patient. So this becomes the input phase, this becomes the processor phase, and then we are seeing on the screen, we can listen to them, and we can store them. This becomes the output phase. So this is in gross the equipment is. And with that, now we begin the first thing, and that is our NCV studies. When we look at the screen looks something like this, right? And this is the NCV which is performed for some nerve. And now we have to check the things and interpret whether this is right or wrong. But this is how grossly the screen looks like. It is like a graph, the graph that we had, that we used to see. And this graph has got the vertical axis as the amplitude axis and the horizontal axis as the time axis. So this indicates the amplitude of the signal, that the potential that we have got, which means the strength of the potential. And this is the time. The parameters are, we give a square wave of 0.1 millisecond duration. The frequency of giving stimulation is 1 pulse per second. And the intensity, of course, varies from nerves to nerves, whether the nerve is superficial, whether the nerve is deep, depending on the patient, the skin type of the patient, and a lot of other factors. The electrodes that we use for NCVs, we have to use one active electrode, we'll come to it, one reference electrode, ground electrode, and we have to have one stimulator. So, motor nerve conduction velocity. Now, if you look here, for any nerve, we have to select, see what happens is, we are stimulating a nerve. So when we give a stimulation to a nerve, that that impulse will pass distally, and it will try and stimulate a muscle that is supplied by that particular nerve. So when a muscle gets stimulated, a muscle contracts. When a muscle contracts, these are the recording electrodes which will record the electrical activity produced, right? So say for example, when we are choosing to do NCV, motor NCV for a median nerve, the distal muscle innervated by a nerve say abductor pollicis brevis, which is a distal muscle. So we will put our active recording electrode, which is always a cathode. Can you see this is a black thing? So this is a cathode which we put over the belly of abductor pollicis brevis. The reference electrode is always an anode, which is put over the tendon of the muscle or over some neutral area. We need to have an earthing electrode or a ground electrode. This earthing electrode is placed at a suitable distance between the two electrodes, or we can also put it over a bony prominence, any bony prominence. So we could have put it over the ulnar styloid or the radial styloid or wherever, or between the electrodes, right? And we have a stimulating electrode which gives electrical stimulation, which we put over a nerve. We have fixed anatomical markings, anatomical landmarks where we stimulate a nerve, and they correspond to the sites where our nerve becomes superficial. So we try to stimulate a nerve. Now that stimulating electrode also has two ends, a cathode and an anode, and we place it over here and then we give electrical stimulation. When we stimulate this nerve, the action potential generated will contract the muscle. This contraction will be recorded by these two electrodes, and whatever happens will be seen on the screen. Right? So once again, this is a schematic explaining the pathways. So here we have put our active recording electrode. Here we have put our reference electrode. Now consider that this is our nerve. Now the first stimuli, say for example, we are trying to stimulate at the wrist. This is our stimulating electrode. And if you see, even the stimulating electrode has got two handles. One is a cathode and one is an anode. And when we stimulate this nerve, so we have given a stimuli here to this nerve, that impulse or that will generate an action potential that will pass distally from here and try to stimulate this muscle, right? So what happens is, we have say given a current here, we have stimulated a nerve and it has passed all over here, and now when the muscle has contracted, that will be recorded by these two electrodes, right? But looking to this distance, of course, this is going to take some time to come from here to here. So when we look on the screen also, we don't get this the potential exactly on the point 0. There will be some time lapse when we give a stimuli and when we get a response. And that first time response is known as a distal latency. Let us name it as T1, right? So when we have stimulated, say, median nerve at wrist, that time taken to give a muscle a contraction and the recording electrodes to record something is known as, that time elapsed is known as a distal latency, which we call it as T1 for the instance. Now we stimulate the nerve proximally. Of course, now when the nerve is stimulated here, that impulse is going to take more time to reach here, and let us name it as T2. Now velocity is distance divided by time. The distance is the distance between these 2 points. The point where we stimulated a nerve distally and the point where we stimulated a nerve proximally. So this is the distance, and the time taken will be T2 minus T1. So that will be the exact time of that action potential to reach from here to here. And then we divide distance upon time, and that is known as x meet, whatever value we get is that much meters per second. For upper limb, the normal value is somewhere around 52 to 55 meters per second. And for lower limbs, it is somewhere around 40 to 45 meters per second. Every nerve has got a different value, but grossly we can say this. You can see a video of how we are doing this NCV. So we have placed the active recording electrode. We have placed the recording electrode. We are placing the ground electrode right now. Let me tell you one thing, the permission to do this study on the patient was taken from the patient and the husband of the patient. So this video is taken with all permissions. Now we are stimulating the median nerve at wrist, and you will see a contraction. You will see the thumb contracting. Now at elbow, yeah. Can you see we have got two things? Can you see this is the distal, this much is the distal latency, this much is the proximal, this has taken more time. We measure the distance between wrist to elbow and then we put the values. Right? Let me play it once again for you. So we have put the active recording electrode. We have placed the reference electrode. We are placing the ground electrode. So now we are stimulating the wrist. This is our stimulating electrode. If you see, there are two handles of the electrodes. Now we are stimulating it. Elbow. We have got the two potentials. If you can see, this time is less than this time. This is at wrist, this is at elbow. We measure the distance and we feed the data. All right? And when we look here on the screen looks something like this. Now, this is what I was trying to say, that when you stimulate at wrist, there is some time taken for that impulse to travel from here to the recording muscle and to get the potential, right? So this much time is our distal latency. When we say that this is a graph, this is the horizontal axis, this is the vertical axis. So on horizontal axis, we have set it so we know what is it. And if you can see here, it is 3.44 milliseconds. So it has taken 3.44 milliseconds for an impulse to travel from wrist to the recording muscle. Then we have stimulated at elbow. If you see, this has taken more time. The time that it has taken is 8.20 milliseconds. Right? Now we feed the distance. The distance is 27 centimeters. Few softwares have an option of giving it in millimeters. In those softwares, we have to convert these centimeters into millimeters. That will be 270 millimeters. And we find out the NCV. And if you can see, it is 56.72 meters per second. So which is absolutely normal. And when you look here, this becomes the amplitude of the potential, right? Because our vertical axis is the amplitude axis, our horizontal axis is the time axis. And now again, the time between the onset of the stimuli to the onset of the peak of the response, this is the onset latency, right? Distal latency is always measured at a fixed distance for every nerve to be able to give normalized values. Proximally, we have to stimulate at some anatomical site, which is there for every nerve. And because the time is less, I'm not able to give the placements of various nerves. Maybe some other time we can arrange that. We will never have a normalized value for proximal latency because the limb length is different for each and every individual. So in that case, we take the NCV values, and if there is a slowing in the NCV, it shows that the problem is at proximal level. So if the distal latency is more than normal or it is prolonged, which means the compression is distally, if the NCV value is reduced and the distal latency is within normal limits, then we can conclude that the problem is there somewhere in the proximal region. Another is the amplitude, which we should understand. And the amplitude can be measured from peak to peak or from base to peak. So there are a few books that measures the amplitude from base to peak, and there are others that measures from peak to peak. Now, in our graph, routine graph, we know that anything above the baseline is positive and anything below the baseline is negative. But in EMG NCV, anything above the baseline is negative, anything below the baseline is positive. So they say that base to the peak amplitude is the amplitude of the negative duration of the potential, and this is the positive duration of the potential, right? And we call it as compound motor action potential for a motor potential and sensory nerve action potential for a sensory nerve. So amplitude represents the total number of physiologically intact axons. So an axon at times may be structurally intact but may not be functional. Say, for example, if in a nerve, we also have a normalized amplitude values. So if in a nerve, if the amplitude is reduced by 50%, then 50% of the axons of that nerve may not be functional physiologically. Normal amplitude for NCV is usually 2.5 to 20 millivolts, depending upon the nerve that we are looking at and the strength of the nerve that we are looking at. Like peroneal nerve, normal amplitude starts from somewhere around 2.9 millivolts, whereas median and ulnar nerve amplitude starts somewhere around 5.5 millivolts. So it depends. It depends from nerve to nerve and even from person to person. Like a well-built person will have more amplitude compared to a sedentary person of the same age and stature. Right? Coming to sensory nerve conduction velocity, it assesses the sensory component of a mixed peripheral nerve. And when we are talking about a mixed peripheral nerve, whenever an impulse travels from distal to proximal, like for a sensory nerve, say there is something which is hot. When our finger touches something which is hot, that heat sensations travel from distal to proximal. It reaches the brain, and the brain gives signal to the motor system to withdraw the finger, right? So efferent is always, it is a feedback and it is always sensory. So for a sensory nerve, the impulse will travel from distal to proximal, and for a motor nerve, since it is an action, it is coming from proximal to distal. Before going for sensory conduction, we should examine one sensory modality, that is a light touch, right? One more thing which is very important is, though we can take the sensory NCV, we can stimulate a sensory nerve proximal and distal, but the recent guidelines says that we just take a distal parameter, we just stimulate a sensory nerve distally, and we consider the distal latency and the amplitude, compare it with the normal. We don't calculate the velocity at all. So sensory nerve conduction can be measured orthodromically or antidromically. Now thinking about orthodromic, for a sensory nerve, anything in the physiological direction is orthodromic, which means that if an impulse is traveling from distal to proximal, it is orthodromic for a sensory nerve. And if an impulse travels from distal to from proximal to distal, it is antidromic because it is opposite to the physiological direction. So when we are doing sensory nerve conduction, and if we are stimulating the nerve distally, we are stimulating a nerve distally, and we are trying to record the potential from the proximal aspect of the nerve. Say, which means that we are trying to, for median nerve, we are trying to stimulate a finger, and we are trying to record that potential from wrist. This is an orthodromic conduction. But if we are trying to stimulate the nerve at wrist and trying to record the potential from the finger, it is an antidromic sensory nerve conduction. These are the two different techniques that are documented. You can do either of the techniques. There are some studies which say that antidromic technique is better or more reliable. There are some other studies that say that orthodromic technique is more reliable. Both have their own reasons, but for a clinical purpose, you can do either of the techniques and it is fine. So SNCV measures large, heavily myelinated axons like touch and vibration sensations. We usually don't measure pain-carrying fibers. They are very small responses, and so they are stimulated also at a submaximal stimuli. We don't give a supramaximal stimuli, and even their amplitude is in microvolts. When we were doing motor NCV, the amplitude was in millivolts. Now that we are doing sensory NCVs, the amplitude is in microvolts. So you can understand how small they are. We always give a submaximal stimuli, and since we are giving a submaximal stimuli, we have to give a series of stimuli and average the response so that we can get a good potential. Ideally, or we can stimulate the nerve across the entire course, the sensory nerve also. But what happens is when we go more proximal, the nerve tends to get deeper, and so we will need more intensity to stimulate a nerve, and in that case we may evoke a motor response. And that is the reason what we do is, say we are talking about ulnar nerve, we stimulate it here, we check with the normal latency value and the amplitude value, and we are good to go. Right? And amplitude will reduce as we go proximally because the nerve gets more and more deeper. We need more intensity to stimulate a nerve, and ideally we should not be contracting a muscle. If we do so, we are recording it from a motor component and not a sensory component. So here is a video. The electrodes which we use for sensory of median and ulnar, they are the ring electrodes. Can you see they are circular electrodes? This is an antidromic technique where we are recording the potential from the, we are recording from the finger and we are stimulating the wrist. So can you see this is a ring electrode which is just tied on the finger. The active recording electrode, now goes the reference electrode. Now we give a stimuli, but the stimuli should not produce a muscle contraction. So it has to be that less, and it should not produce a muscle contraction. There is no muscle contraction, and yet if you will look on the screen, there will be a response which will be there. Can you see the response? Yeah. And this is the average response. Right? There is no muscle contraction, yet we are seeing something, right? So ideally we are good to go with this, and we have to record, we have to average. Now we are done with it. See what happens now. We are trying to stimulate distally, and something that I want to show you. Can you see? Now we are trying to stimulate proximally, and see, we are getting a muscle contraction, which we should not get. Right? We should not get a C. And when you look at the shape, see, this shape is different from what we got previously. This is a broader one, which is a mixed nerve coming up. We don't want a mixed nerve. We want only and only a sensory nerve. And that is the rationale why we don't usually stimulate a nerve proximally, right? So when we are doing an antidromic conduction, this is a median nerve. These are our electrodes. We put our stimulating electrode here. So we stimulate a nerve from the wrist. That impulse will travel here and the activity will be recorded here. This is stimulating proximally and recording distally. We will get the antidromic nerve conduction. Whereas in orthodromic conduction, these electrodes are connected to the electrical stimulator, which means that we are now stimulating the fingers and we are recording from the median nerve. And then when we get it, this is an orthodromic conduction, right? So the areas of placements will remain the same. It is just that these are the stimulating electrodes at this instance when we are doing orthodromic conduction, and these are the same are the recording electrodes when we are doing antidromic conductions. And these are attached to a different place. So on an equipment, we have sockets for attaching the stimulating electrodes. We have sockets for attaching the recording electrodes. And when we put these electrodes in those sockets, they become vice versa. So when you stimulate distally and record proximally, it becomes an orthodromic technique for a sensory nerve. And when you stimulate proximally and record distally, it becomes an antidromic conduction for a sensory nerve. And grossly, when we look at it, this is the shape of the potential which we normally get when we stimulate a motor nerve. And this is what we get when we stimulate a sensory nerve. So can you identify the difference in the two shapes that we get? This is very broad. This is very narrow. If you look at the amplitude, this is in millivolts. If you look at the amplitude, this is in microvolts. We have to stimulate a motor nerve using a supramaximal stimuli. We have to stimulate a sensory nerve using a submaximal stimuli. But this is what, and why I am emphasizing on this is, maybe I'm not expecting you to perform EMG NCV studies right away, but you are, I'm sure, as a clinician or as an academician, you must be coming across your patients where they would be coming to you with their EMG NCV reports, and the reports are usually given with the graphs. And when you look at the graphs, you should come to know whether this is a graph of a motor nerve or a sensory nerve. So you have a steep, sharp shape, though in a motor sensory conduction, whereas you have a broad and a bigger shape for a motor conduction. So that was just the very, very short basic of NCVs. And now we go for electromyography. Electromyography is a study of muscle function through the inquiry of electrical signals. Once again, here also we are not measuring the power of a muscle. We are not measuring the strength of the muscle. What we are measuring is the electrical activity that are produced within the muscle. And we can use this for research, for rehabilitation. When we are using EMG biofeedback, we are using it for the rehabilitation purpose. For certain analysis, we can use in ergonomics, we can use in sports, of course, in the clinical practice, this is widely used. The contraindications, as such, there are no absolute contraindications to EMGs, but coagulopathies, the places where there is a risk of infections, and the specific sites like chest or abdominal area. When we are doing needle EMG, you need to be highly trained and qualified when you are trying to assess a muscle that is present over the chest wall. or over the abdominal area, because you are risking pneumothorax or peritoneal insertion. So the EMG studies can be performed using a surface electrode. These are the same electrodes that we were using for NCV. Okay, the electrodes are same. The only difference is when we are doing NCVs, we are giving an electrical stimulation to the nerve. Here we don't have to stimulate. We are just placing the electrodes and trying to record the activity. So these are again the same surface electrodes which are placed over a muscle to be tested. And we can also do EMGs using a needle electrode. The needle looks something like this, and within this black core or a hollow space, there are platinum wire, which is your electrode. So this platinum wire becomes your active electrode, and the shaft of the needle or the outside stainless steel cover of the needle becomes the becomes the reference electrode. And this needle is to be inserted over a muscle. Of course, there are specific landmarks wherein you insert the needle. And if you can, and if you are using for a clinical purpose, we should be using needle electrodes. We cannot give any clinical interpretation of the patient if we are using the surface electrodes. So surface electrodes are very easy to operate. At the same time, the diagnostic precision and diagnostic accuracy can achieved only because of the needle electrodes. We all know what is a motor unit. It is one anterior horn cell, its axon, its neuromuscular junction, and all the muscle fibers that are supplied by that nerve fibers, right? So this constitutes one motor unit. So if we look here, we have two different motor units, and this is how the fibers are interspersed in between, right? And what we are trying to basically record is the activity coming from the single motor unit, right? So grossly, our EMG examination is divided into three phases. One is the insertional activity, that is when we are inserting the needle. That exactly when we are inserting the needle, something comes on the screen. I have videos to show, I'll show everything. So that activity we have to record, and we have to say whether this is a normal activity or an abnormal activity. After inserting the needle on the muscle, we have to completely relax the muscle. And when the muscle is relaxed, there will be some activities which will be coming if the muscle is abnormal. In a normal stage, of course, there is electrical silence, but otherwise in a pathology of a nerve or a muscle, there will be some activity coming up, which we call it as spontaneous activity. And after recording the spontaneous activity, we tell the patient to gently contract the muscle and try to analyze individual motor unit action potential, after which we give a maximum voluntary contraction, that is, we give a resistance to the muscle and try to see what comes on the screen. And then we analyze whether this is normal or abnormal. So grossly, we examine the muscle at three stages. One is when we are inserting the needle, then we relax the muscle and analyze, and then we tell the patient to contract the muscle and try to analyze. So just look at see what happens is when we are inserting a needle, we are trying to irritate a muscle fiber membrane, and that produces certain sound and something on the screen. That is known as an insertional activity. Just see. Can you see that? Yeah. Now it has stopped. So it was silence here. This is when you started inserting the needle. This irritated the muscle fiber membrane. And once you stopped inserting the needle, the activity has gone. This is an insertional activity. Look at the video once again. This is a silence. Needle is inserted. and a silence once again. So ideally, in a normal condition, this activity stops when you stop irritating that muscle fiber membrane or when you stop moving the needle, right? In certain pathologies, in a nerve pathology or in an acute nerve injuries, this insertional activity is increased than normal. And in myopathic conditions, because you don't have muscle fiber membranes or there are less muscle fibers, the insertional activity is reduced compared to normal. So we make our analysis whether the insertional activity is increased or reduced, and we can conclude. We have now inserted the needle. Now we are telling the patient to relax. After the muscle, when the muscle is in a relaxed stage, and still if we are getting some activity, it is an abnormal sign. There are various spontaneous activity that come, and depending there are all, remember one thing, you will not get all these activities in one patient, but depending on what abnormal activity you have got and correlating with the clinical findings, you will conclude that this patient is having these conditions. So various spontaneous activity includes fibrillation potentials, positive sharp waves, complex repetitive discharges, fasciculation potentials, myokymia, neuromyotonia, and cramp. Right? So these are all different spontaneous activity that we get, that we see. All the activities are not present in one patient, but depending on what we are getting, we will get 1, 2 or combination of maximum 3 activities in a muscle. We may get only 1 activity in a muscle, but depending on what activity we are getting, and we are trying to correlate that with the clinical findings of the patient and other EMG NCV findings and make our conclusion. So the first abnormal activity is the fibrillation potential. If we look at the fibrillation potential, we see something, the potential, the muscle is relaxed, yet what we see is we see a sharp biphasic wave of a very low amplitude with always an initial positive deflection and a subsequent negative deflection. So this sharp biphasic small wave, when we look at the screen, at the same time, we hear the sound like rain falling on rooftop. Like we have our AC thing, and when the raindrops fall, they produce a typical sound. When we see this kind of a thing, with the sound that we hear, we are sure that these are fibrillation potentials. These fibrillation potentials are the diagnostic of LMN condition, the lower motor neuron condition, anterior horn cell lesions. So the diagnostic of nerve injuries are fibrillation potentials because there are increased number of acetylcholine receptors in a denervated muscle which develop hypersensitivity. So this is how your fibrillations look on the screen. Can you listen to the sound? Yes, they are sharp, biphasic, and the sound is like rain falling, small raindrops falling on the rooftop. Listen to it once again. So when you get this kind of thing, this is known as a fibrillation potential. And when the muscle is relaxed and you see something like this, and when you hear the same kind of a sound, you are sure that this is fibrillation potential, which is suggestive of a nerve injury. Another are the positive sharp waves. The names describes they are a sharp positive deflection and a prolonged but a very low amplitude, almost looks like a baseline. It's a prolonged negative deflection and a sharp positive deflection, looks like a sawtooth, and these are known as positive sharp waves, and they are always and usually accompanied by fibrillation potentials. They have a dull sound, and just look at the video. Can you see this with positive sharp waves coming? You can see fibrillation potentials also in between. Right? So you have a combination of positive sharp waves and fibrillation potentials here. Right? So you have fibrillations also in between. You have got positive sharp waves also. And this is how a picture comes when you check a denervated muscle. Then comes complex repetitive discharges. They are extended train of potentials of various forms. They come usually in burst or continuously of a single motor unit. They keep on coming. Their sound is like a diver bomber. When the diver bomber planes are moving, they give a zoom kind of a sound. And when you get these kind of potentials with this diver bomber sound, this is usually seen in neurogenic atrophy, polymyositis, and a lot other conditions. Just look at the video. Can you listen to this sound? Yeah? It was just like a plane, the fighter plane moving, right? So when you get that kind of a sound, it is a complex repetitive discharges. Once again, right? This is diagnostic of neurogenic atrophy at times in polymyositis and certain other conditions involving anterior horn cells. We do get complex repetitive discharges. Fasciculation potentials, all of us know because we also usually get a fasciculation potentials, but fasciculation potentials are not an abnormal findings by themselves if they are accompanied by certain other neurological signs and symptoms. Then and then only we should conclude that these are abnormal fasciculations, and usually fasciculations are caused due to irritation or degeneration of anterior horn cell, and if they are present with the other clinical findings, they are diagnostic of motor neuron disease, amyotrophic lateral sclerosis, syringomyelia, tetany, etc. But when we are getting it, it is a benign thing. Many times we get it in our some muscles and they stop abruptly, and it is not an abnormal finding. Remember one thing, fasciculations accompanied by the clinical neurological signs and symptoms are only pathological. And when we get this usually what happens is certain irritated motor units start contracting abruptly, and that shows on the screen, and we can see that on the skin also, right? And when we get this along with the other signs and symptoms, then it is an abnormal fasciculation. Here in this video you will look for the fasciculations here also and on the screen also. Can you see it? right? So these are the fasciculation potentials, and when present, they are diagnostic of motor neuron disease, amyotrophic lateral sclerosis. Mainly, they are the diagnostics of anterior onset lesion, whether at a single level, at a multiple level, or generalized motor neuron problem. There is something which is known as myokymia, which are again spontaneous muscle potentials or motor unit contracting, but their pattern of contraction is different. Like we had abrupt contractions in a fasciculation, whereas here the movement will be like a worm. When you see a worm moving, the worm does not move straight. It just goes up and then down and moves forward. So when you look at that kind of a pattern, especially on the facial muscles, and then you see something like this on the screen, this is a myokymia. And facial myokymia is usually found in multiple sclerosis, brainstem neuroplasms, polyradiculopathies, and at times in facial nerve pulses. And we find it when we find it in the limbs, it is seen in the radiation plexopathies. We all know myotonia is an inability of a muscle to relax. So when a muscle is continuously in a contracted stage, the continuous firing of motor units will take place, and that will keep on coming on the screen, right? And these are found in the syndromes of continuous muscle fiber activity, anticholinesterase poisoning, tetany, and times in spinomuscular atrophy. And during a surgery, say if a surgeon is approaching a nerve or trying to damage the nerve, and if we are trying to monitor it intraoperative, we will see these kind of continuous muscle activity keeping on coming, which we may call it as neuromyotonia. And the last is the cramp potentials. We already know, all of us must be having cramps at times, when a muscle suddenly contracts and then it gives way on itself. And when the cramp is coming, somehow we are not able to control that cramp. It will come and it will go on its own. But when we get that kind of a thing, it is a cramp potential. So it is a spontaneous discharge of potentials occurring at 40 to 60 hertz with an abrupt onset, and it will stop also abruptly. And they occur in salt depletion, chronic myogenic atrophy, myxedema, pregnancy, uremia. And when we get it, we have to understand that we have to increase the fluid intake, right? So again, cramps are also not by themselves an abnormal findings. Just maintain your hydration and you should be fine. Now we have checked the spontaneous activities. We have tried to see what we are getting. Fibrillation potentials, positive sharp waves, fasciculation potentials, complex repetitive discharges, myokymia, neuromyotonia, and cramps, right? Whatever we are getting, correlating with the clinical findings, correlating with the other electrodiagnostic findings, we will frame our conclusion. So now we have checked the muscle when it was in silence. Now we will give a voluntary contraction. We will tell the patient to gently contract the muscle and try to check the motor unit action potentials, and they represent the sum of muscle action potentials. These are coming from the individual muscle fibers of the same motor unit, and when the summation takes place, something like this, a biphasic wave comes here on the screen, and this is your motor unit action potentials, okay? And we are trying to see motor unit action potential. We are trying to identify, we are trying to interpret them and try to say whether this is normal or abnormal. So your motor unit examination is assessed with respect to the amplitude, that is the peak to peak amplitude. What is the amplitude? We definitely have a normalized values for various muscles. Then the duration, that is the time from when it began to when it stopped, that is the duration of motor unit action potential. We try to analyze the shape, whether this is a biphasic potential, a triphasic potential, or a polyphasic potential, and its frequency. Right? So When you look on the screen, if you get the motor unit action potentials are usually biphasic or triphasic. Normal motor unit action potentials are biphasic or triphasic. So if you analyze here, if you can see, this is a biphasic potential, this is also a biphasic potential, this is also a biphasic potential. So these all are coming from different MUPs, okay? And that is why you are getting, though they are all are biphasic, they are different shape. If you look here, this is a triphasic potential, one phase, second phase, and the third phase. So this is a triphasic potential. This is again a triphasic potential. This is again a triphasic potential, and this is also a triphasic potential. So in a normal muscle, say if you are sampling 10-15 motor units, majority of them or should be the biphasic and triphasic. If the phases are more than 3, say 4 phases, 5 phases, we call them as polyphasic MUAP, and polyphasic MUAP is the sign of abnormality. So this is how, if you look here, can you see? Phase 1, 2, 3, 4, and 5. So this has got 5 phases. When you get continuously these kind of potentials, MUAPs, this is an abnormal finding. Presence of polyphasicity itself for more than 10% in a muscle is an abnormal finding. So say if you are sampling 5 different motor units, of that 10 different motor units, if one is polyphasic, it is acceptable. But if more than one motor units action potentials are polyphasic, it is an abnormal finding, and presence of polyphasicity itself suggests abnormality. What abnormality? Will come to it, right? Fine. So this is about motor unit. Now, whenever say there is a nerve injury, axonal injury, and axonal injury, axonal degeneration is usually followed by re-innervation. And there are two means of re-innervation. A nerve may re-innervate with a collateral sprouting, or a nerve may regenerate with a direct regeneration of original nerve terminal. Let us see what happens in both the cases. So say in a nerve, when there is a partial nerve injury, so this was an uninjured axon and this was an injured or degenerated axon. Now say this axon was supplying these 4 fibers, 4 different muscle fibers. Now the fibers supplied, 2 fibers supplied by this is degenerating. What will happen is this normal fiber will try to innervate this because they have become orphans. These muscle fibers are degenerated, they have become orphans. So this normal nerve fiber will try to adopt these 2 orphan fibers. Okay, now what will happen? Already it had got these many fibers, and with only these many fibers, if this was a normal shape, triphasic, now it has started innervating the dead fiber, the denervated fibers, which means now instead of 4, it is supplying 6 fibers. Your amplitude will be increased because now the 6 fibers are going to contract instead of 4. So you will have a high amplitude. At the same time, because these 2 fibers are farther away, it is going to take more time to recruit. And so what you will have, you will have polyphasicity also, and you will have a longer duration. So when you have a large amplitude, long duration, and polyphasic MUAPs, it is usually a regeneration by means of a collateral sprouting, right? So presence of polyphasicity itself is an abnormal finding, but at the same time, it is always also indicating that the re-innervation process is going on. So when the re-innervation is by a collateral sprout, you will have large amplitude, long duration, and polyphasic motor unit action potential, right? And once they get matured, that large amplitude will still be there, and that is what we call it as a giant MUAPs. So when we, on examination, if we see giant MUAPs that is of a very large amplitude compared to the others, we should understand that this is a regenerated muscle. Now, let us say that this was degenerated. This was partly degenerated, which means that initially it was supplying 6 fibers. Now, of the 6 fibers, 2 have got degenerated. So what happens at first instance, its amplitude is going to reduce. Now the redirect reinnervation process has started, but it is not yet regenerated. So when the process has started, yet what we will see, because initial regeneration, the myelination will be thin in the terminal sprouts, we will get a polyphasic MUAPs, but the amplitude will be low. So low amplitude polyphasic MUAPs will suggest direct regeneration. So anyhow, high amplitude polyphasic suggests regeneration by a collateral sprouting. Low amplitude polyphasicity suggests regeneration by a direct supply. And when that it gets mature, it mimics its original shape. Okay, so we have regeneration with a collateral sprout, wherein also we will get a polyphasic MUAPs, and we have regeneration with a direct sprout, with a direct reinnervation. Then also initially we will get polyphasic MUAPs. So presence of polyphasicity in a nerve injury itself is an abnormal finding, and it is suggestive of degeneration with regeneration. And so if you try to see these 3 different waveforms, this is a normal waveform. These both are polyphasic potentials, but this is a low amplitude, short duration polyphasic MUAPs, and this is a large duration and long duration, large amplitude and polyphasic MUAPs. We know that we get this in a nerve lesion with a collateral sprout, and this we get in a nerve lesion with a direct regeneration. At the same time, even in myopathy, say a patient is having a myopathy wherein the number of fibers of the motor unit will be less, right? Because the fibers are replaced by the necrotic tissues. So that is when also we get low amplitude, short duration and polyphasic motor unit action potentials, right? So we have, again, I'm telling you, always and always have a clinical correlation so that we can conclude whether this is a myopathic condition or whether this is a neurogenic condition. But presence of polyphasicity in itself is an abnormal finding. Now we tell the patient to do a strong muscle contraction, and we get a dance pattern of superimposed potentials, which we call it as interference pattern. So if you look here, can you see a dense pattern? You are not seeing the baseline, and if you look at it, something that rises gradually and falls. So this kind of a pattern, when we get, this is an interference pattern, and this is a complete interference pattern, right? Can you see? This is, once again, this is a normal complete interference pattern. This is what we get in a normal muscle when we try to give a strong resistance or maximum voluntary contraction of that muscle. But say if a muscle, if there is a partial degeneration of that muscle. Now, can you see the difference between this and this? This is a reduced interference pattern wherein you can see baseline in between, and you can see the pattern is also not complete. The pattern is giving away halfway, right? Compared to this. So this is a reduced interference pattern. And when there is a severe degeneration, say hardly 1 or 2 motor units are surviving in a muscle, you will get this kind of a discrete interference pattern. Can you identify the difference? This is a normal interference pattern. This is a reduced interference pattern which we see in a nerve injuries. And this is again discrete interference pattern which we again see in nerve injuries. Now, Whenever we have a case of nerve injury with regeneration, what we get is, we all know that we get high amplitude MUAPs or the giant MUAPs. So when we see something like this on the screen, it is a chronic neurogenic case. But in myopathy, we know what happens is the nerve is intact. The problem is with the skeletal muscle fibers, where our skeletal muscle fibers are partially absent, replaced by fat tissue. So in one motor unit, say out of 10, 5 skeletal muscle fibers are not there, but the 5 are there. So when we give resistance, those 5 will contract together. And so though we get a dense pattern, the amplitude will be reduced. So when we see something like this is seen in a neurogenic case, and this is this kind of a pattern wherein the amplitude is less, the density is more. We see it in a myopathic case. So you know what a normal interference pattern looks like. What when it is reduced, that is few fibers are degenerated and few are still there, and a discrete pattern. In a neurogenic case, we will get high amplitude IPs, and in a myopathic case, we will get a dense low amplitude IPs. So this again will make us differentiate between a neurogenic case and a myopathic case, and make us differentiate, if it is a neurogenic case, make us differentiate what is the severity of that partial nerve injury. Right? So grossly, if we have to summarize our EMG findings, we have normal insertional activity. This is like what we see in a neurogenic lesion and what we see in a myopathic lesion. We get fibrillation potentials and positive sharp waves usually in a neurogenic lesion, large amplitude polyphasic MUAPs, and fast firing with a discrete pattern. Whereas in myopathy, we have fibrillation potentials if it is an inflammatory myopathy, or it will be silent if it is a non-inflammatory myopathy. But the MUAPs will always be low amplitude, and the IPs will always be full but with low amplitude. Okay. Now, a fast overview of F waves. Because of time constraint, I may not take it into depth, but F wave is it is variable in latency, amplitude, and configuration, and it is the only parameter in nerve conduction studies which is useful in the diagnosis of peripheral nerve lesions. Now, it results from antidromic stimulation of motor neurons involving conduction to and from spinal cord. I'll explain it to you. See, what happens is, now this is your muscle, okay? You have stimulated the nerve here, just like what we did in the NCV. The first impulse will travel and you will get the wave which we used to get in NCV. So this is your compound motor action potential, or we call it as main wave. At the same time, this impulse of course is going to travel in the proximal direction also. So this will reach the anterior horn cell and take a turn. Now here when it reaches, it will depolarize some axon, and that will be carried through the axon that has got stimulated here. The same motor unit will contract, but that impulse has gone up. So the time elapsed will be, it has gone up, it has depolarized, and it has got down, which means the time is quite more. So besides a little bit away from your main wave, you get a very small wave which we call it as F wave. So it is an antidromic stimulation of motor neurons involving conduction through and from spinal cord. It is not crossing the opposite side, just at the anterior horn cell lesion. Every time it goes up, every time it stimulates a different motor unit, and every time you get a response. So by default, every F wave has got a different shape. Now, since it is recruiting only one motor unit at a time, the amplitude of F wave is always small. So that is why it is said that F wave is variable in latency, because every time it is recruiting a different motor unit, every time it is um, coming and recruiting different numbers of fibers, which may be near, far, wherever. And so it is variable in latency, amplitude, and depending on what motor unit it is recruiting, every time the shape will be different. And so to perform the F wave, we have to give a series of stimulations. We have to stimulate that nerve at least 20, 30, 50 times, and with a supramaximal stimuli, right? So a supramaximal stimulation is applied. The impulse travels both distally towards the muscle fibers and proximally to the anterior horn cell, and from where it comes back. So can you see, this is how the F wave looks like. And if you analyze these are the series of stimuli given. Every shape is different. Every latency is different. Can you see? This is beginning from here. This is beginning from here. Now this is beginning from a little bit farther away. So every F wave looks different. Every F wave has got a different latency, right? The afferent and efferent of F waves are alpha motor neurons, and they are produced at a supramaximal stimuli. And F waves are the diagnostic of proximal nerve problems. So we usually use F waves for radiculopathies. Of course, the specificity is very less, but yet at times we use F waves for proximal pathologies. And the more important is we are using a lot of F waves when we have got acute AIDP kind of a patient. So in acute peripheral neuropathies, we should be doing F waves. Coming to H reflex, they are described by Hoffman in 1918. They are monosynaptic reflex elicited by submaximal stimulation, and H reflex is present only in two muscles. One is soleus for tibial nerve and another is flexor carpi radialis for median nerve. If you find H reflex in any other muscle, it indicates upper motor neuron lesion. The reflex arc includes large, fast conducting group 1A fibers, the spinal cord where there is a synapse, and then you have efferent motor fibers. So this is a reflex. F wave was a wave. F wave and H reflex both are late responses. One is a wave because it does not cross the opposite side or it does not involve the sensory component. H reflex involves a sensory component. It makes a reflex arc, and that is why we call it as reflex. It does not include muscles spindle activation. Rest of the arc is similar to the tendon reflex, which is produced by muscle strength. It is elicited on submaximal stimuli and inhibited on supramaximal stimuli. So in F wave, we give supramaximal stimuli, but for H reflex, we have to give submaximal stimuli. So again, the muscle selected is soleus. These are where we put our electrodes. We stimulate tibial nerve in the popliteal fossa. What happens is it forms the reflex arc, the sensory and the motor. And what we see here, that initially when our stimulating amplitude is less, we get H reflex, can you see? And once we go to a supramaximal, we get the main wave, but the H reflex diminishes. So H reflex is always got with the submaximal stimuli, and it disappears at a supramaximal stimuli. Okay. Once again, here also we have to take care of the H reflex latency. The shape of H reflex is going to be same throughout. Remember that part. The shape of the H reflex is going to be same throughout. It's just variable. The amplitude changes, and the H reflex is usually quite high amplitude, right? So again, showing the origin, It does not, F wave does not cross the sensory part. It just remains localized at the anterior horn cell. Whereas if you look at H reflex, it goes to the sensory cortex, sensory part, dorsal root ganglion, and the sensory component, makes a synapse, and you get a motor component, right? So this is the difference between the F wave and H reflex. The amplitude of F wave is very small, just 5% of the main C map, whereas the H reflex is 50 to 100% of the M amplitude, main wave amplitude, right? For H reflex also, you will have to give a series of stimuli. Just from zero, you keep on increasing the intensity till you reach the maximum, and till the H reflex diminishes, right? So in F wave and H reflex, you have to give a series of stimuli. They are again painful. H reflex also is the diagnostic for proximal problems, but it is seen only in soleus and FCR. Rest of the nerves, it is not there, whereas F wave is present in almost all the nerves. The advantage of H reflex is it also evaluates the sensory component of a nerve compared to F wave, where it evaluates only the motor component of a nerve. So this was just the basic idea. So in all, what we do, we select a test, we select the appropriate parameters, we perform the test, we record whatever we get on the screen, we have our cursor markings for latency, for amplitude, for duration, we adjust the cursors, and then we interpret the potentials. But if we look into EMG versus NCV, NCV is excellent for identifying demyelination, whereas EMG is gold standard for axonal injuries. NCVs identifies entrapments. EMG is gold standard for radiculopathies and myopathies, and it gives the timings also, whether it is acute, subacute, or chronic, which is not seen in NCVs. So you have to use both the techniques together in majority of the cases, except for some wherein the guidelines have said that you can diagnose it only with the help of NCV. So if somebody says that I am doing only NCV and trying to make my interpretation, it must be an incorrect interpretation, because you have to use a combination of both, because both have their own advantages and disadvantages. So the different nerve disorders that we are seeing is, we doing EMG NCVs, we can find out the axon lesion, the myelin lesion, the mixed axon and myelin lesion, the conduction block. We can, in a peripheral nerve injury, we can predict the site, extent, and type of nerve injuries, and we can also conclude about the prognosis of that injury. We can also diagnose disorders of muscles and neuromuscular junctions like muscular dystrophy, neuromuscular junction problems, extent and severity of nerve injuries, and of course the prognosis of that condition. There are certain anterior horn cell conditions which we can diagnose using these studies, like motor neuron disease, spinomuscular atrophy, cervical myelopathies. All this also we can diagnose using these kind of studies, right? So a brief about the clinical interpretation. When we look into a nerve injury, we know that the nerve injury is axonal, demyelinating, or a combined. Now, what happens in an axonal degeneration? As we know that amplitude indicates the physiologically active axons, right? So if there are less physiologically active axons, it will reflect in the amplitude of the potential. You may get a normal NCV because the myelin sheath is intact. What is affected are the axons inside that myelin sheath. So timing issues will not be there, but amplitude will be less. See what happens here. Say this is your nerve, and these are all different axons. This is a normal nerve. So you see that there are these many fibers supplying that nerve. Now, if there is a partial axonal injuries, which means now only half of the fibers are conducting an impulse, half axons have degenerated. There is no problem with the myelin sheath. Your myelin sheath is intact. So the timing, the saltatory conduction and the timing of conduction is all preserved. What is affected are the number of axons. So you can see here there are very few axons functional. So this is going to reflect in the amplitude. So say if this was normal in an axonal injury, this is an abnormal finding. So when you have a pure axonal lesion on the second day, still we all know that axonal degeneration starts after 6 days. So if you perform your NCV on the second day, your amplitudes are going to be normal and same. Can you see here, right? Similarly, even on the second day, if you are stimulating at a site which is proximal to the nerve injury, can you see? The amplitude at the distal sites are normal, but past this, it is not going to conduct. So what you get is the distal amplitudes will be normal, but at the site of injury and proximal to the site of injury, the amplitudes are reduced. Can you see the comparative amplitudes? This is much reduced compared to the distal ones. Okay. Now, so at this stage, if on the second day we are performing NCV, we will come to know that there is something abnormal. But whether this is an axonal injury or this is just a neuropraxia, we will not come to know. We will definitely not come to know whether this is an axonal injury or a neuropraxia. For that, we will have to wait for some time and say when we are now performing on the 7th day. So these axons have now absolutely degenerated on the 7th day. So now what we have are only the few axons that are there, and just now compare the amplitudes. All the amplitudes are reduced. It was 8 previously, which is now come down to 4, which means all amplitudes are reduced. But if you look at the NCVs are all well within the normal limits. So we should not be performing these studies at least for 7 to 10 days post injury. Otherwise, we may not give proper conclusion. But we can say that we will have low amplitude in an axonal injury with normal NCVs and normal motor latencies. All right. So when you are looking at the table, say you've got a patient and you should now start looking at the tables, and on the table, if you see reduced amplitude with normal NCV, they are diagnostic of an axonal injury. Coming to demyelination, now your myelin sheath is responsible for the faster conduction of a nerve, and you have a saltatory conduction, right? So for a faster conduction of a nerve, you need a myelin sheath. Now, when that myelin sheath is injured or affected, that saltatory conduction is not going to be there. So what will happen? The latency will be prolonged because now there will be timing issues. The faster conduction is gone, which means that impulse will take longer to propagate. So there will be timing issues. There will be change in the shape of the potential. Can you identify the different shape? So this was a normal shape. Can you see this? This has become very broad. This was the normal latency. Just look at the latency, which means that there are timing issues in demyelination. So what we get will be prolonged latencies and reduced NCV values, right? So now if you look here, say there was a compression of nerve at this site, that is at elbow. Now what happens is you stimulate the nerve at wrist, your latency is normal, your amplitude is normal. Now you stimulate ulnar nerve below elbow. Again, if you look at the amplitude, it is pretty normal, right? and your NCV 59 meters per second is normal. The compression is at elbow, which means the myelination is affected here. So the saltatory conduction is not going to be here. So now when you have stimulated above elbow, that impulse will be passing from this wherein there is no myelin or there is an injured myelin, which means it is going to take more time. The amplitude is still normal, but now look at the NCV value. This is 59, this is 40. You are still stimulating up proximally at the axilla. It still has to pass through this compressed segment. But this segment is normal. So NCV across this segment is going to be normal. NCV across the affected segment is going to be reduced. So we may have a prolonged latency and reduced NCV in demyelination. So what happens is in a normal nerve, all the response arrive at the same time because of the presence of myelin sheath. And that is why we get this sharp biphasic potential. But in a demyelination, the response is because that myelin control is not there. The responses arrive at different times. So can you see? Now let us see what happens. Say your myelin, say you all are going in one bus. So that bus is taking you all to a place at the same time, right? So we have a party and we are going somewhere, sitting in a bus to that party. All of us are going to reach at the same time to that party, right? Because we all are sitting in the bus. So this bus is our myelin sheath. And so we all are reaching at the same time. But instead, now the myelin is not there, the bus is not there, and all of us are walking at our own speed, which means we are not going to reach there at the same time. All of us are going to reach at a different time, and so we will get a dispersed shape. We will get a phase cancellation. We will not get this kind of sharp shape. And when we get this kind of a shape, this is known as temporal dispersion. And temporal dispersion is the diagnostic of demyelination. And this is how it looks. Now, can you see the difference? You have seen the previous shapes and just see. This is temporal dispersion. And temporal dispersion is the diagnostic of demyelination. Remember that. So, we have reduced amplitudes with normal latencies and normal NCVs in an axonal condition. We have prolonged latencies and reduced NCV values and at times increased temporal dispersion in demyelination. Right? And there is last thing which is known as a conduction block, which is failure of an action potential to propagate past a particular point. Say there is a frank compression. Say it is just like we have a scar and that scar is compressing a nerve. So what will happen when the nerve is getting compressed? The myelin is also affected. The axons are also compressed. Axons are there, but they are compressed and so they cannot propagate an impulse ahead. And so what happens is we see a reduced amplitude, we see a prolonged latencies, and when we see the combination of both, it is known as a conduction block and it is defined for upper extremities as greater than 20% drop in CMAP amplitude from distal to proximal area. So wrist and elbow, say, ideally they should have the same amplitude. But if at, say, wrist, the amplitude is normal, but at elbow, the amplitude is much reduced, and the NCV across that segment is also dropped, then that is known as a conduction block. It is something like this here. Say there is a partial conduction block here. So these fibers are getting compressed, right? So what we see is the latency is also prolonged, the amplitude is also reduced, right? So this is known as a partial conduction block, right? So identification of a conduction block is greater than 20% in the CMAP amplitude across the portion, along different components of the same nerve, And remember, conduction block is reversible. You remove the source of compression and that nerve will be normal again. But if you don't remove that compression if keeps on persisting, that will in a longer run lead to Wallerian degeneration or the axonal degeneration of the axons, right? So here we have a nice case study just to be able to explain you how I am making my interpretations. Say we all know about cubital tunnel syndrome or ulnar nerve lesion at elbow. And if you look at the anatomy of the ulnar nerve, it passes behind the medial epicondyle and supplies the medial aspect of the comes to the medial aspect and supplies the medial aspect of the hand. Now, at just in the forearm, there is a branch that comes out which we call it as dorsal ulnar cutaneous nerve, which supplies the posterior medial 1/3 of the hand. At the wrist, the nerve divides into one hypothenar branch, the digital sensory branch, and the deep palmar branch. The hypothenar branch supplies the hypothenar muscles. The digital branch supplies the medial 1/3, that is the little finger and medial half of the ring finger. The deep palmar branch supplies the flexor pollicis, the lumbricals, the interossei, and the flexor pollicis brevis, and the last muscle supplied is adductor pollicis, right? So in Guyon's canal, it divides into three branches, that is the hypothenar branch, the deep palmar branch, and the digital branch that gives a sensory supply to the digit. In the upper forearm, the nerve gives a dorsal ulnar cutaneous nerve which supplies the dorsal 1/3 of the hand and index and ring finger. So this is gross anatomy of your ulnar nerve. And so here we have a case of this lady who had gradual onset of tingling and numbness over the ulnar aspect of the right hand. There was swelling which was present on the right elbow, which was very visible. And she had hypoesthesia along the course of ulnar nerve in the hand and dorsal ulnar cutaneous nerve course. Right? So we performed the NCV. Now, if you look at these values, I'm sure it is hard for you to understand. But for your convenience, let me say that the distal motor latency, if it is more than say 4, it is 4 milliseconds, it is abnormal. And for NCVs, for median and ulnar, somewhere around 54-55 meters per second is the normal values. So what I have done is I have performed NCV for median nerve, wherein I have stimulated the wrist and elbow. Traditionally, ulnar nerve has to be tested at wrist, below elbow, and above elbow. But so this is what I have done for the ulnar nerve. And I have also tried to use one advanced technique, that is, I have tried to test it the deep palmar branch. And so I have tried to do NCV of ulnar nerve for the first dorsal interossei. Okay. So now if I have got this table, there are certain places where I would like to look at, or which would take me to my conclusion. Look at this distal motor latency of the right median nerve, which is 4.6 milliseconds. Remember, patient did not give any symptoms for the median nerve. Yet the NCV of median nerve is reduced, which is suggestive of some kind of demyelination, right? Prolonged latency, distal motor latency, and reduced MNCV with normal CMAP amplitudes, right? Now coming to the ulnar nerve, the first thing that will come to my mind is, instead of above elbow, it is elbow, which means that that swelling was there, which did not let me stimulate the above elbow site. The latencies are normal for the ulnar nerve, you can see. What is alarming are the amplitudes. Can you see? All the amplitudes are reduced, but more reduced is the amplitude at elbow. which means there is axonal degeneration, but the source of compression is at the elbow. And just, my God, look at below elbow to elbow NCV. Just 29.4 meters per second, which means it is severely, severely reduced. So this is pointing out at conduction block. Okay. I have tried to do first dorsal intraossei also. Once again, I have not been able to stimulate above elbow. So I stimulated at the elbow. Now look at this. If you look at these amplitudes are better, isn't it? But this amplitude is still reduced and markedly reduced, which means that deep palmar branch is better than the hypothenar branch but in terms of amplitude, yet the abnormality at the elbow side still persists. And this is just a minimal reduced NCV, borderline reduced, I can say, right? So these are the things I would look at on this table. I could do sensory conduction only for the median nerve, which apparently looks pretty normal. I could not do sensory conduction for ulnar nerve or dorsal ulnar cutaneous nerve. Then I tried to do needle EMGs and I tested abductor digiti minimi, abductor pollicis brevis. Abductor digiti minimi is the hypothenar branch of ulnar nerve. Abductor pollicis brevis, we know that for the median nerve. First dorsal intraossei, that is the deep palmar branch of ulnar nerve, and I tried to do flexor digitorum profundus for little finger because I wanted to make sure whether the lesion is at the elbow or at the wrist, and if at the elbow, what is the status. And if you can see, we could see fibrillation potentials in all the ulnar supplied muscles. We did not get it in excuse me, median supplied muscles. But at the same time, we have got polyphasic MUAPs in all the muscles, which means that there is acute degeneration present in ulnar supplied muscles. And if we talk about median nerve, polyphasicity is there, which means there was some denervation, but it is not acute because fibrillations are not there. Yes, I cannot say that yet this is normal, but patient does not have symptoms, which means it was a subclinical presentation. So if you look at my conclusion, forget what I have written here because I have to describe everything, but my conclusion is severe partial conduction block of right ulnar nerve at elbow because there was swelling, the amplitudes were less, the NCVs was severely reduced. It was just 29.4 meters per second at the across elbow with subacute partial axonal degeneration. Why subacute? Because I saw polyphasic also and I saw fibrillations also affecting the hypothenar branch. Yes. Deep palmar branch. Yes, because all had got fibrillations and polyphasic. Digital branch and dorsal ulnar cutaneous because there was no potential which was elicited, which means the nerve has not regenerated. Signs of minimal early regeneration is seen in the hypothenar branch because the amplitudes were still quite reduced. But good regeneration seen in the deep palmar branch because the distal amplitudes were almost normal in the deep palmar branch compared to the proximal amplitude. And there is no regeneration which is seen in the digital branch and dorsal ulnar cutaneous nerve. Now, though the patient did not have any symptoms of median nerve, my electrophysiologic testing has also suggested subclinical compression of right median nerve at or about wrist with minimal segmental demyelination of the nerve. And because I had got polyphasics, it is chronic partial axonal degeneration, but the nerve has good interference pattern, so there was a good regeneration. So stepwise, we have to look at the tables and we have to make our interpretations. What you people do is you just look at the interpretations, whether it is right, whether it is wrong, but there are certain key points that you have to remember. Reduced amplitude, axonal, prolonged latencies, reduced NCV, demyelinating, combination of both, conduction block, presence of fibrillations, acute and subacute degeneration. Absence of fibrillation with polyphasicity is a chronic degeneration with regeneration. Fibrillation potentials with polyphasicity is subacute. Just this is all, and it is actually very simple. But there are still certain pitfalls with EMG and NCV testing, like anatomic variations. We know that morphologically there are a lot of anatomical variations in the normal human subjects also. There is a problem with the reference values as far as Indian population is concerned, because we are still not able to find out reference values for Indian population. We are still following the Western values. The temperature, if the temperature of the room is less than 30 degrees, we may get a mistake because we will get a prolonged latencies. If we are stimulating a nerve at an excessive intensity, which means we may make technical error, stimulate an adjunct nerve, and we may get increased NCVs. And yes, we have to be very, very careful in making a diagnosis. And as an electrophysiologist, instead of writing CTS, we have to write compression of the nerve, because writing CTS caters a higher responsibility. The tests are examiner dependent because technical soundness and proper training is mandatory. It is not easy. The better you are with your techniques and hands-on skills, better studies you can perform and more accurate will be your results. Though EMG NCVs are highly specific tests, the sensitivity is less. Then we have to be very strict with the protocols that we are using, because excessive testing will give again false positive results. But what we see is, when we look at the reports that are coming to us, what we see is they do everything in all the patients, which ideally should not be done, right? And another biggest pitfall is EMG NCV test does not assess the central nervous system mind well. We are just testing the peripheral nerves. To do the central nervous system assessment, we have to go for evoke potentials like motor evoke potentials, somatosensory evoke potentials, etc. This is just a brief introduction to intraoperative neuromonitoring. That is what the instrumentation is absolutely different. We are doing evoke potentials for the spinal and brain when the patient is on operation table for the spinal and brain surgeries. And we are trying to monitor the functional integrity of these structures during surgery. We have to work in close association with the orthopedic or the neurosurgeon and the anesthetist. We have to correlate our findings with the level of anesthesia that the patient has. Of course, this requires a lot of training and a lot of practice. The purpose of IONM is to reduce the risk of iatrogenic damage to the nervous system. And studies have said that we are able to be 50%, we are trying to reduce the risk of nerve injuries by 50% if we are doing intraoperative monitoring along with the surgeon, right? And they provide the functional guidance to the surgeon. So if we get some abnormal finding, when the surgeon is placing the screws on the pedicle or on the vertebrae, and we say that, hold on, you are approaching the nerve, the surgeon can say that the surgeon will change the alignment of the pedicular screw, and we can save that portion of a nerve or a spinal cord. So different things are done, like we do somatosensory evoke potentials, we do motor evoke potentials, we do free run or spontaneous EMGs, we do triggered EMGs, and we do combined multimodality IONM. We can go for intraoperative neuromonitoring only and only after learning EMG NCVs. And then when we do this, we are in the operation theater till the time the surgery is performed, and we are able to guide the surgeons, we are able to save the nerves or the neural structures of the patient. We are catering a huge responsibility, and this is very much upcoming in India. So when we are doing motor evoke potentials, We are trying to detect the surgical insults that are done to the ventral part of the spinal cord. When we do somatosensory evoked potentials, we are trying to analyze the surgical insults to the dorsal column of the spinal cords. And when we are doing free run EMGs during the surgeries, we are monitoring selective nerve root functions. So the purpose of IONM is to detect response changes due to surgery. We are not making any clinical diagnosis. We are just trying to guide the surgeon. Here, hold on, you are approaching a nerve or a neural structure, and we are trying to save that nerve. Right? And why should we do all this? Because when this, I am sure this is too much for everyone, and this is just the basics. So why we should learn? Because, and we all are here to earn money, and I'm sure all of us want to earn money, right? So if we look at the Indian scenario, EMG NCV testings are underrated and at the same time overrated. Few feel that any technician can do it, and we physiotherapists feel that, oh my God, this is so difficult. But as a matter of fact, 10th pass technicians are doing these studies. So I'm sure you people are better people to do it than anyone else. The fear of the study being difficult is one of the biggest hindrance that we physios are facing. We have apprehensions of false notion, improper knowledge and guidance because we are not guided well. Your teachers must have said it is difficult. Your teachers must have said that it is not a cup of tea of a physiotherapist. That is why you are not doing, but it is not right. There is huge open market awaiting, just that we need proper training and we have to prove ourselves. Of course, as I said, there are no reference values available in India. So there is a huge scope of research in India, and there is a lot of money in the clinical setup. So there is inadequate research even for normalized values. We lag behind Western countries in generating evidence-based data for electrodiagnosis. Even when we look at the Cochrane database, there are hardly very few studies that are done on EMG NCVs. Quantitative EMG is absolutely unexplored in India. If we look at a clinical scenario, each test costs around 2,500 to 4,000 rupees per patient. There are very few physiotherapists who are doing it. The cost of an equipment is less than a physiotherapy center setup. Believe me, the cost of an equipment is very, very less compared to a physiotherapy center. The space that you need is very, very less. Again, that saves your money. But most important, you should be trained, you should be certified, and you should be trained properly and systematically. It is not that anyone can do it. If you look into United States, because I am a faculty for an academy in United States and I'm trained in United States, as per the data of 2014, there were only 165 physical therapists across USA who are certified EMG practitioners. ABPTS certified means American Board Physical Therapy Specialist certified. If you clear this ABPTS exams, you can do EMG NCVs independently in United States. You can supervise people who are studying or who are getting trained in EMG NCVs, and you can stand parallel to the doctors. In United States, Medicare permits and pays certified physiotherapists to practice the test. So if somebody says that physical therapists cannot do EMG NCV in United States, it's a bullshit. Each study can pay you about $800, which means that you do one study, it may take you 2 hours, you are earning $800 compared to when you are doing a job of a PT, I guess you can earn almost up to $150 per hour. That is the highest side that I'm talking about. American Board of Physical Therapy Specialists, ABPTS, has developed an examination for select physical therapists that perform electrophysiology testing. You need to pass that exam. So if you look at United States, if you look at this graph, all the blue areas are the places where you can do EMG NCV testing. These yellow part are silent, which means we are not sure whether we can do or not, but it is only in this much area EMG NCV is prohibited. Rest across the entire United States. If you are certified, if you are specialist, if you have passed the exams, you can do EMG NCV studies even in United States. So Medicare provides coverage for EMGs, that is, I'm talking about needle EMGs that are performed by physical therapists. Certification in clinical electrophysiology through ABPTS is mandatory in United States. Medicare allows certified clinical electrophysiology therapists to personally supervise other therapists also. So the system goes that like that. You do a course on EMG NCV, then you have to work under somebody's supervision. After doing a few cases, say around 250 cases or so, you are eligible to appear for ABPTS exams, right? So this Medicare allows the certified electrophysiology physical therapist to personally supervise also the other trainee physical therapists. And the analysis of Medicare claims a steady increase in a number of needle EMGs that are filed by physical therapists in recent years. Now, of course, I agree that each state in United States has a different law for performing needle EMGs. Our California State Board, because I'm trained in California, the California State PT Board and Consumer Protection Board permits certified physical therapists to perform needle EMGs. Of course, we all know that USA welcomes good researchers. USA has excellent infrastructure and highly sophisticated equipments and labs. So what is needed? Aptitude and dedication, ethics. Of course, you need to be very sound and logical in your clinical skills. You cannot do it haphazardly. Correct technique of performance. You should know how to analyze and correctly interpret what you have got. And most important, good training. You should be properly trained. Now there are certification courses available even in India wherein you can get trained and certify yourself for EMG NCV. You can contact Parole University if you want to get certified for EMG NCV testing. Please don't try to find shortcuts. This is my message to the younger generation. I know you want to make faster money, but please don't try to find shortcuts because nothing can replace hard work. So it is your choice whether it is easy way or hard way. But this is always my last slide saying that you all would have seen some people succeeding, that oh my god, this fellow is so successful, but only that fellow knows how much hard work, how much disappointment, sacrifice, failure that person has seen before you get success. So success is always an iceberg and nobody knows what that person has gone through in this struggle, and I have struggled for 23 years to be able to reach at this stage. So nothing replaces hard work, persistence, and dedication. Right? So thank you for listening to me patiently. If you have any queries, you can approach me by WhatsApp or on my email. And thank you very much for listening to me.
Thank you so much, ma'am, for this amazing lecture. The knowledge that you have shared with us, it was wonderful. Indeed, you rather what to say, the title which was given to it, it was quite appropriate the way you explained everything. You made it quite easy. And the kind of motivation that you have provided for all the fellow physiotherapists is also commendable. So thank you so much for taking time for IAP and IAPWC and sharing your knowledge with all these physiotherapists across the globe. And once again, I would like to thank Gaurav Patel sir and Parole University for providing us this platform to cater all the physiotherapists over here. To all the participants, I thank you very much for showing interest in large number again and trusting IAP and IAPWC. Thank you so much. We'll keep staying in touch with you and we'll keep coming for more and more to you. Thank you.
I
Thank
would
you so
like
much.
to I would like to add on to it. I would like to thank everyone who has trusted me. And I guess there are more than 1,000, 1,500, I guess more than that participants viewing right now. So yes, I heartily thank you all for trusting me and for uh, considering my worth. I would like to thank Indian Association of Physiotherapy and Indian Association of Physiotherapy Women's Cell and Parul University for providing me this platform. Thank you so much.
Thank you, Nehal madam, for such a wonderful webinar. It was a great experience where you have a teach. I make sure that all the therapists will learn a lot many things from your side. And if anyone want to enroll the course for in the EMG NCV course, they can approach to our university. We are conducting the EMG NCV course in association with the American Academy of the Clinical Diagnosis. So it is a certified course. For more details, you can approach us or log into our university, so you can have a better idea of this particular course. Thank you, madam.
Thank
Thank
you.
you.